Centre for Viral Hemorrhagic Fever patients in Victoria, and in all likelihood a known suspected case would probably be transported directly to the designated hospital. But we do know that in the event of a self-presentation, an initial management plan is required before coordination with the designated centre. Other possibilities include the presentation of an Ebola patient who is too unwell to transfer, or the unlikely event that the designated hospital is unable to accept any more patients. So for these reasons, we needed to implement an Ebola plan into our organisation. With regard to hospital experiences outside of West Africa, Richards et al. Published a case report in 2000 whereby standard precautions were sufficient to protect healthcare workers against transmission from an unknown Ebola case in South Africa. Similarly, in the US and Western Europe, there have been several patients cared for with Marburg, which is a virus closely related to Ebola, with no healthcare-associated transmission, despite a lack of transmission-based precautions prior to diagnosis. So I think prior to the developments in recent weeks, these experiences made us feel reasonably confident in our ability to safely manage a case utilising appropriate precautions and PPE. However, as I'm sure you are aware, a Spanish nurse tested positive to Ebola on the 6th of October after caring for 2 confirmed cases repatriated from West Africa. And more recently, 2 nurses in Texas have tested positive after caring for another known case in the US. So although we don't know exactly how transmission came about, it is concerning as these were known positive cases and PPE was available, although whether or not it was adequate is also unknown. So I'm sure a lot of people will be familiar with a few of these headlines, and I think these are leaving us to review our plans and implement them as a matter of priority. So in this webinar, I'm going to cover the rationale behind our chosen isolation precautions. I'll discuss personal protective equipment that has been agreed upon at our organisation and how we plan to safely remove it. I'll cover a bit about the rollout of training here, and finally some of the staff responses that we are experiencing. So according to the CDC, it does appear that Ebola virus can be spread through airborne particles under experimental conditions in animals, and this has actually never been demonstrated in human outbreak settings. So up until 2 days ago, the CDC and state and federal governments were recommending contact and droplet isolation precautions with airborne for aerosol generating procedures, and that the patient be cared for in a single room with a private bathroom. So although these recommendations were evidence-based, it has generated a lot of internal discussion. For example, evidence about transmission versus acceptability to clinical staff, that these were essentially the same recommendations for influenza versus the additional risk introduced through use of unfamiliar PPE, such as the powered air purifying respirators, or PAPR. So it is stated in the Victorian Ebola response plan that whilst the routine use of PAPR may be appropriate in some situations, routine use of this higher level PPE might increase the risk of self-contamination due to unfamiliarity. It may decrease the frequency of clinician contact with the patient. It may inhibit examination and diagnostic tests. And finally, it might increase costs, waste and patient anxiety. So something a little bit controversial that has been a concern to some people was well highlighted in a commentary posted on the ACIPC a few weeks ago, and it is the question of whether droplet and airborne transmission can be considered mutually exclusive, in that emitted particles may be widely distributed in size. So although the risks might be very small, I think it is an interesting thought, and I would be interested to hear people's comments on this. So when we got to work yesterday, as I'm sure was the case with a lot of people, we arrived to the news that the CDC had upgraded the recommended PPE to include PAPR or an N95 mask. The reason behind this being that in the event that an unexpected aerosol generating procedure may occur, so not because they're actually saying that it's airborne. So we have designated negatively ventilated rooms as we have this facility, although in saying that we have decided that our neg vent room in ED will be used in neutral to allow for an additional exit to be used to assist with PPE removal, just allowing extra space. So safe PPE removal was something that we did prioritise over negative ventilation. We have up until this point taken a staggered approach to PPE with low risk for suspected viral hemorrhagic fever patients without bruising, bleeding, vomiting or uncontrolled diarrhoea, and high risk, which would be used for suspected viral hemorrhagic fever patients with these symptoms or a confirmed case. So this was all under review yesterday afternoon in the response to the recommendation that no skin be exposed, because our low-risk PPE actually had some exposure around the neck and the face. I think like many organisations, with regard to equipment, we did consider the use of a full-body suit, but our major concern was safe removal. We did try this a number of times with Glitterbug and found that it was extremely difficult to remove without self-contamination. We also preferred gowns, as staff were familiar with these. We did already have impervious gowns, but we have ended up sourcing impervious gowns especially for this situation, which are a bit more breathable and slightly more pleasant to wear. We are going with tight-fitting goggles, long gloves, hoods and leg covers, none of which were stock items. So we reviewed a number of different samples before deciding on what to order. And I mean, for example, we found some goggles had perforated sides, some boot covers were too short, some ripped too easily. So this has taken quite a bit of time to get right. We did already have PAPA systems in our ICU, which were purchased in preparation for SARS a number of years ago. However, these are in short supply, so given that we are not the designated centre and at this stage we don't anticipate having to provide prolonged care for these patients, we will be quarantining our used PAPA hoods in a box, which we will either discard or reprocess depending on a result. So this is a picture of our low-risk PPE, which is currently under review, as I said. So it's made up of disposable scrubs, an impermeable gown, one set of long gloves, an N95 mask and tight-fitting goggles. And you can see quite a bit of skin exposed on the head there, head and neck. These are our two high-risk PPE combinations. So again, disposable scrubs. We've got gumboots, long boot and leg covers, impermeable gown. We've got two pairs of long gloves and either the PAPA unit or N95 mask, tight-fitting goggles and hood. So we're also just now considering the use of a face shield in addition to the mask and goggles, just because a lot of people are not able to get full coverage of the skin on their face with what we're currently using. Now, PPE removal is also something that has generated a lot of internal discussion. These are two different recommendations from the CDC. Example 1 recommends gloves first, followed by eye protection and gown. Example 2 recommends gown and gloves together, followed by eye protection. So in all our other guidelines, we had adopted example 1, as had the NHMRC, and in fact, in their updated guidance, the CDC are recommending an order similar to this. However, when it comes to Ebola, we felt much more comfortable leaving the face fully protected whilst the gloves and gown came off, so protecting mucous membranes from splashes and also avoiding potentially contaminated gown sleeves coming up near the face. So WHO also recommends leaving the face protected whilst the gown and gloves come off. And this is actually the removal process that we are recommending. So first of all, gown and outer gloves together, followed by shoe / leg covers, followed by inner gloves, and then some hand hygiene. Then headwear, whether it's the PAPA system or the N95 mask and goggles and hood, followed by more hand hygiene, and then finally gumboots using a shoe remover. So all of our PPE is going to be removed in the ante-room, and a buddy will always be present in the ante-room to assist. So as you will notice, we haven't incorporated anything about the decontamination of gloves, which I know is a controversial issue, and there has been a lot of discussion about this on the ACA list this morning since the updated CDC guidelines. So again, I'm interested to hear people's thoughts about this. Now, just moving on to education, we have had sessions with, within our team to ensure that we're all familiar with this process. We've also had a couple of sessions with the other metropolitan healthcare organisations in Melbourne to review processes. And whilst we're not all exactly the same for reasons such as infrastructure or equipment choice, we are quite similar, which is reassuring. With regard to education of clinical staff, as I'm sure everyone is finding, this is a mammoth task. We are trying to get people to attend more than one session so they can be really confident in what they are doing. Our focus is on ED, but as a contingency, we are working with ICU, and they're actually very keen as they don't want to land in the deep end in the event that they unexpectedly have to care for an Ebola patient. We are in the process of developing videos showing the application and removal of PPE, and we've actually already filmed twice, but we just keep needing to make updates, so these are currently a work in process. We have now scheduled regular weekly sessions in ED for their senior doctors and nurses. These go for 1.5 hours, and we're trying to get people to attend a few sessions, as I said. In ICU, we're using more of a trainer-trainer model, whereby the first session by a new trainer is observed by infection prevention. We've had a couple of sessions with lab staff in the event that they have to package up a specimen for transportation, and also our infectious diseases registrars in the event that they are called in. So for those of you who have read the updated CDC guidance, it does use the word competency a couple of times, so this is certainly something that we are now considering. We now have a viral hemorrhagic fever guideline, which is up to version 19, and I suspect version 20 is on the way after the updates. There has been extensive input from the following groups of people, and currently it's approved as a working draft pending final endorsement. So it is very important that we do publicise this guideline widely, given the major variations to usual patient management and flow. It has been distributed to senior staff in ICU and ED, and along with all of our PPE training, we are highlighting the key points of the guideline. And just finally, staff responses. I suspect that other organisations may be experiencing this. It is quite an emotive issue for staff. Coupled with a fear of the unknown, we are seeing a lot of images in the media which are contributing to anxiety. And certainly the transmission to healthcare workers in Spain and the US has really scared people. We've had questions raised about whether staff can refuse to care for patients, and also a lot of questions about what are the clinical limits and how much treatment we would actually offer. So in an attempt to allay fears, we will be running a hospital Q&A session with one of our ID physicians. That's actually on today. We've also worked really hard on our communication to reassure staff that we are prepared and we do have a plan. But ultimately, I think the more education we do, particularly regarding use of PPE, the more confident staff will feel in their abilities to care for an Ebola patient. And just finally, I have added the point about what I've called infection prevention public relations. I think, as was the case with SARS, as more and more information comes to light and the world gains more experience with Ebola, guidance changes and we are continually updating the recommendations in our local guidelines. And I think it is important that staff understand and recognise this for what it is, rather than incompetence on our behalf. So again, I think that transparency and communication are key. And that's all I have. So thank you very much for listening.
Thank you, Gemma. We've and that's been very interesting. Now, in terms of questions, if people would like to, I will unmute everybody, and we might just go through. We'll just try very gently and see if people would like to ask a question. And what I'd ask you, if you just wouldn't mind telling us your name first of all, and then we can take it from there. So I'm just in the process of unmuting everybody now, so that might just take a while. If you haven't put an audio pin in, unfortunately I won't be able to unmute you, but you'll probably see it from your login. So I guess whilst I'm doing that, Gemma, I might say this is an evolving field, basically, and this is happening all the time. And so, because you say it's basically something you do on a daily basis.
That's right. Yes.
That be right?
Yep. Yep. Absolutely.
And how are you working on a team basis? Clearly, you're working with other experts in this field, or you, who do you relate to each day to get the latest information about what's going on and what policy changes have been?
I think we're constantly checking everything that's coming out. Certainly, our physicians, our whole team is involved, and I think that there is a lot of communication between networks as well that goes on.
Okay, whilst I've got you there, Gemma, are you able to see the question panel?
I think so. I can't see any questions in there at the moment.
Okay, I had a note here from, I think Sandra Wharton said she had an unanswered question, but I just can't seem to find it. So Sandra, if you are online and you have a question, please feel free just to announce yourself and ask it.
Gemma, thank you. It's Sandra Wharton here. Thank you for that. That was very informative. I just wonder why we don't have national guidelines and why each state has individual guidelines.
Yeah, I mean, and that's a good point. And I think a lot of hospitals are reinventing the wheel. I mean, we are trying to communicate with each other as much as possible, but certainly I think a lot of hospitals are putting in a lot of resources into their Ebola plans. It's a good point.
This is perhaps something we probably need to discuss at policy level within the college, I would imagine, isn't it? Whether we can play a role in this. There has been some action on this. I'm not aware of the latest details, but I know Ramon Chaban has been meeting with people at, I think, the Health Ministers' Council last week, but we might find some more information out and get it out to members. Any other comments or questions? Everyone virtually is unmuted now, so I know someone's typing. Anyone got a question?
Hi, Steve.
Just like to announce yourself. Yes, just announce yourself so we know who you are.
So Atkins, Department of Health, Victoria. Gemma, are you willing to share your list of PPE requirements, putting on, taking off, your levels of risk?
That was in the presentation?
Yes.
The low risk and the high risk?
Yeah.
Yes, I think we would be happy to share that. Yep.
Which Steve,
as I said, the low risk is under review currently, so I'm not sure where we're going with that, but certainly I think we can share that.
Would you be willing to have it on the college website for us to access?
Is that okay, Steve?
Yes,
yes,
that's your call.
It's okay for us.
If it's your hospital organisation, whether they're prepared to share it, I would imagine there would be a willingness in this instance. It's not a problem. I'll speak with you offline afterwards, Gemma.
Yep.
Just to
I'll run that past the team, but I think it will be fine.
Okay, that would be very helpful. Thank you.
Any other comments or questions there?
Steve?
Yes, it's Barbara Elliott. Yes.
It is. It's Barbara Elliott from St John's in Subiaco in Perth. Good morning. It's very early for us. Gemma, that was great. We're a private hospital without an ED, and we don't expect that we will have a presentation acutely ill. However, we do a lot of elective surgery that people turn up the night before or morning off, having not been asked the question. And obviously we've got a lot of staff anxiety like everybody else has.
Yeah.
Are you able to share what kind of communication or information you're planning to speak with your staff?
So this afternoon we are having a Q&A session with staff. It's going to be presented by one of our ID physicians. I think he's going to give some facts about Ebola, some background, and I think it's just important that they understand that we do have a plan, that we are training the ED and ICU staff, and that basically we are in a position to manage these patients. So probably we are going to show them the PPE that will be used, just so it's not so much of a surprise for people. But certainly I think that the key points of the guideline and where the differences are to normal patient flow and management.
Thank you. Gemma, Sandra Wharton again. I was just wondering whether your staff, how have they found donning all that PPE? And how long do you expect staff to actually wear, for how long do you expect them to wear that at any one time?
I think it's definitely not comfortable, and certainly the PAPA is a lot more comfortable than wearing the PPE with the hood and the mask and the goggles. I think it will depend on the individual and how they're feeling when they're in the room. It is hot, and I expect people will probably become very quickly dehydrated. So I don't think we'd expect staff to stay in the room not using PAPA for a prolonged period of time, but certainly it is not comfortable. Staff aren't finding it very comfortable when they're not using the PAPA.
Thank you.
Gemma, it's Susan Martland here. I'm just really interested in your thoughts on recommending using only safety engineered devices, particularly for blood collection and IV insertion. I recognise this is a difficult area when you've got so much PPE on, but it is concerning certainly with these patients if you were to have one, just doing simple procedures like blood collection. So what are your thoughts on that?
Yeah, look, that has been a concern with a lot of our staff here. Certainly when you've got multiple layers of gloves on, I'm not sure what the answer is. I mean, we'll certainly be recommending that staff perform the bare minimum amount of tests required. But sorry, you mentioned safety engineered devices?
Yes.
In terms of,
so
I mean, all of our devices are all safety devices here at the hospital.
Okay, well that's great. I know that certainly in some other institutions that may not be the case. So
okay, yep.
It would be of interest perhaps with any guidelines that are being developed, maybe to just have a point made there to ensure then that there is consistency across the board. Just a thought.
Yep, yep.
It's Stephen here, Gemma. I've got some questions that have come in. One from Susan Martland, which I think you've just answered on safety engineered devices. There's one from Janine Malcolm. What cleaning guidelines have you recommended? You may have already answered that, but I just thought I'd just remind myself.
With regard to cleaning, we're not involving our environmental services. If we were to have a patient, we're trying to minimise the amount of staff that go into the room. So we're recommending that nurses are performing spot cleans until the patient actually leaves, in which case there are some cleaners, some senior members of the team who will be trained up to perform that terminal clean. Yep.
Good. Which I guess leads on to the next one from the question from Megan Brown. Wondering if anyone's tackled the question of staff quarantine. I think you did mention that in your presentation about the incidents with a Spanish nurse, but anything on the local area?
I think that's something that's also under review at the moment. I don't know if there's anyone else who'd like to comment on that.
Open to the floor. Would anyone like to comment on the issue of staff quarantine?
21 days.
There are still quite a number of people online, but all right. Well, look, Gemma, we might move on to the next one, which was cleaning and waste management. That was a question from Tina Quirk, I think, from the ACT. Now, you've talked about cleaning. What about waste management?
So we are everything is going to be clinical waste. All of our waste is going to be double bagged. We're solidifying any human waste before it gets discarded. And I believe this will be collected by our environmental services. The outside of the wheelie bin will be wiped over with bleach, and it will be taken downstairs and secured.
Okay. And the last question we had here at the moment was from Megan Brown again. Also interested in people's thoughts about methods of achieving communication between staff in the room and the ante-room with the rest of the unit.
Yeah, and I would also be interested to hear people's thoughts on that. Obviously, we want to avoid the use of anything going up near the face, such as phones. I think we do have an intercom facility, but I'm not sure how useful that will be when you have got your ears covered by all the PPE. I'm interested to hear other people's comments on that also.
Anyone would like to comment on that? Well, while you're thinking about that, and I guess it's to do with staff, there's a question here from Mari Somerville. Once they're identified, how long does it take to activate your Ebola team and get them all dressed in the PPE?
That's a good question. We haven't. We are planning on doing a simulation in the next few weeks, so that is certainly something that we will need to determine. Obviously, we don't want people rushing, so getting dressed, making sure you do everything in the right order certainly can be quite a slow process. So I don't expect that it's something that can be activated immediately. It would take a little bit of time. But I mean, certainly in the meantime, we could quarantine the patient while we do get everything organised.
So what, 10, 15, 20 minutes to get dressed?
Maybe 10, yeah.
Yeah, okay. Any other comments or questions? No, I think, well, that may well be it, I think, Gemma. Just so you know, what I will do to everyone who's online at the moment, I'll send you out a survey, and we will be able to take questions on this. I'll organise somehow for you to send an email with your questions to here as a clearinghouse, and we'll forward them on to Gemma. We'll work out some process whereby we can do that. There is, of course, the ACA list, discussion list, which is alive with this conversation at the moment. So please, if you haven't joined, you can get onto it via our website. Just go into the search engine and put in ACA discussion list, and it's fairly straightforward to join. There's a lot of very interesting discussion that's in real time. Anything else that you'd like to add as a closing comment, Gemma?
Thanks, Steve. I think that we're all in the same boat, and as I said previously, this is something that is constantly evolving. So certainly open to comments and feedback if anybody has any. But thank you very much for listening.
Okay, and I certainly will be organising to get the recording. We'll do some technical work on that, and as soon as it's up, we'll be letting everybody know. But to access it will be for members only because of the intellectual property rights, so you'll need to be a financial member to access them. the members page. But now with that comment, I'll thank you once again, Gemma, and thank you to everyone with your forbearance for the technology. As I say, this is the first time the college has had more than 50 people online for a webinar, and I think it's gone fairly well given our few difficulties. Be safe and be nice to the college, and we'll no doubt be in touch again. Thank you, everybody.
Thanks, Steve.
Thank you.
Thank you. Bye.
Thank you.
Bye.